Hi, I'm Nicole Aaronson. I'm a pediatric otolaryngologist, also known as an ear, nose, and throat surgeon. Today I'm going to talk to you about a peritonsillar abscess, what it is, and how it's managed. So there is a space between the tonsil and the back of the throat and the muscles next to it called the peritonsillar space. And sometimes in a case of an infection, pus and bacteria can accumulate in that space. And so how do you tell a peritonsillar abscess from a regular case of tonsillitis? So the symptoms can be a little bit different. There can be significant unilateral throat pain. There can be a lot of difficulty swallowing. There can be pain in that same ear where the throat hurts. There can be sometimes a sensation that it's harder to breathe, and there can be difficulty opening the mouth. On physical examination, what we often see is that there can be a fullness or a bulge in the back of the soft palate on that side. Sometimes the uvula, the hanging thing in the middle, can be shifted toward the opposite side, and sometimes there can actually be kind of a squishy, fluctuant feeling if that area is palpated. A lot of times we'll notice a muffled, we call it a hot potato voice on exam, where it sounds like the person has a hot potato in their mouth that they're trying not to burn themselves with. And there's often significant trismus, which is difficulty opening the mouth, and this occurs because of inflammation of those jaw muscles from the infection. So a lot of times a peritonsillar abscess can be very obvious just on history and physical examination. If it's not clear, or the symptoms and the exam are discordant with one another, something like a CT scan can always be obtained to get some imaging and see if there is a true pus pocket there. If there is a pus pocket and it's very small, say less than 1 centimeter in size, it's reasonable to start with IV antibiotics, especially in a patient who hasn't had any antibiotics, and see if their symptoms improve. In larger abscesses, or ones that have not improved with IV antibiotics, the optimal treatment is incision and drainage. In an adult or in a teenager who is amenable, this can sometimes be done in the emergency room or on the floor. However, in a small child, this is always going to be done in the operating room. When I do an incision drainage of a peritonsillar abscess, I always start by localizing the pus pocket with a needle and trying to obtain a sample of pus for culture. Sometimes if the patient has been on a lot of antibiotic, the sample might not grow out anything, but oftentimes some bacteria will grow, which will help to direct antibiotic management after the fact. Once I've gotten my sample of pus, I sort of widely open that area with a knife, and then I sort of spread in that pus pocket to break up any sort of loculations or little septations within the pus pocket. I then flush aggressively with saline to flush out that abscess cavity and help to get all of that pus out of there. We do not typically close the incision, as we want any further pus to be able to drain out. When the patient wakes up, relief is usually pretty marked and pretty immediate from these symptoms. Usually patients with one peritonsillar abscess don't necessarily need to consider a tonsillectomy. However, if a second peritonsillar abscess occurs and this becomes a pattern, then tonsillectomy is something reasonable to consider. So in short, a peritonsillar abscess is a pus pocket sort of in the space next to and lateral to the tonsil. When it is very small, it can be managed with IV antibiotics, but when it's larger, it will require incision and drainage, either asleep in the OR or awake in an emergency room, depending on the patient tolerance. Patients with repeated peritonsillar abscesses should probably consider a tonsillectomy. Thank you so much for listening to this video. If you have suggestions for topics, feel free to drop them in the comments. And if you want to see more videos like this, please follow Dr. Nicole Knows. Thank you.